Hello, everyone, and welcome. Today, we'll be diving into the fascinating world of drugs used to treat hematopoietic disorders. This is a critical area of pharmacology, especially for nurses and medical students, as these medications play a vital role in managing various blood related conditions. Let's get started. Think of it this way: blood is the delivery truck of the body, bringing oxygen and nutrients everywhere they're needed. When something goes wrong with how blood cells are produced, it can lead to fatigue, infection risk, or even life threatening bleeding. So, the medications we'll talk about today are like powerful tools to fix or boost that delivery system. Let's begin with a quick review of hematopoiesis. This is the process by which our bodies create new blood cells. It all starts with stem cells in the bone marrow, and this process is carefully regulated by hormones like erythropoietin and thrombopoietin, as well as growth factors. Understanding this fundamental process is key to understanding how these drugs work. Imagine a tree with many branches. The stem cell is the trunk, and the branches grow into red cells, white cells, and platelets depending on what the body needs. These hormonal signals are like gardeners directing how that tree should grow. Here, we see a more detailed view of hematopoiesis. Notice how the pluripotent stem cells differentiate into various cell lines, ultimately leading to the production of erythrocytes, platelets, and leukocytes. The body's needs constantly influence this process, ensuring we have the right balance of each type of blood cell. This balance is delicate. Too few platelets, you'll bleed. Too few white blood cells, you're vulnerable to infection. Understanding these pathways helps us target medications precisely. Now, let's talk about how we can use growth factors as pharmacotherapy. Thanks to recombinant DNA technology, we can now create these factors in the lab and use them to stimulate the production of erythrocytes, leukocytes, or platelets. This is particularly useful in conditions like renal failure, anemia, and bone marrow suppression. These drugs are like boosters that help patients recover their blood cell counts faster after chemotherapy or illness. Thanks to biotechnology, we can literally copy the body's own hormones in the lab and deliver them when the natural system fails. Erythropoietin, or EPO, is a key player in red blood cell production. When the body senses hypoxia or low oxygen levels, the kidneys release erythropoietin. This hormone then stimulates the red bone marrow to produce more red blood cells, increasing the oxygen carrying capacity of the blood and restoring balance. His same hormone was misused in sports for performance enhancement, but in clinical settings, it's life changing, especially for patients on dialysis who can't make their own EPO effectively. Let's focus on some specific erythropoiesis stimulating agents, like darbepoetin alpha and epoetin alpha. These are commonly used in patients with chronic kidney disease or anemia caused by chemotherapy or HIV treatment. However, it's crucial to be aware of the potential adverse effects, including hypertension and the risk of cardiovascular events. Quick tip: always check the hemoglobin levels before administering. Overcorrecting anemia can cause the blood to thicken, raising the risk for stroke or heart attack. That's why the FDA gave it a black box warning. As nurses, we play a vital role in managing patients receiving erythropoiesis stimulating factors. This includes careful monitoring of blood pressure and cardiovascular status, as well as educating patients on proper injection technique. Remember, these vials are for single use only, and the medication should be stored properly. Here's a pro tip: always rotate injection sites and instruct patients not to shake the vial, just like with insulin. These proteins are delicate. Moving on to colony stimulating factors, or CSFs. These drugs like filgrastim, are used to rapidly increase the number of neutrophils in patients with immunosuppression. This is especially important for patients undergoing chemotherapy or bone marrow transplants, as it helps to prevent life-threatening infections. These drugs are especially important in cancer care. Filgrastim acts like a wake-up call to the bone marrow. Hey, we need more neutrophils now. That way, patients stay protected during chemo cycles. Continuing our discussion on colony-stimulating factors, remember that filgrastim should not be administered too close to chemotherapy. Also, be aware of potential side effects like bone pain and thrombocytopenia. Close monitoring of white blood cell counts is essential to prevent serious adverse effects. Always double-check timing with chemotherapy. It must be given at least 24 hours before or after to avoid suppressing its effects. And keep an eye on WBC count. If it climbs too high, patients could experience serious complications like respiratory distress or even splenic rupture. The nursing process is crucial when administering colony-stimulating factors. Encourage frequent rest periods and fluids, and carefully evaluate for both therapeutic and side effects. Patient education on infection control measures and subcutaneous injection technique is also paramount. Encourage hand hygiene, monitor temperature daily, and stress the importance of reporting any signs of infection, no matter how minor. Even a low-grade fever can be dangerous for immunocompromised patients. Here's a quick reference table summarizing the key colony-stimulating factors, including filgrastim, pegfilgrastim, and sargramostim. Pay close attention to the routes of administration, dosages, and potential adverse effects. Remember, the underlying effects are the most serious. Clinical pearl. Pegfilgrastim has a longer half-life than filgrastim, which means fewer injections. Great for patients who want to reduce clinic visits. Now, let's discuss platelet enhancers, specifically oprelvecin. This drug is used to treat thrombocytopenia by stimulating megakaryocytes and increasing platelet production. Be aware of the potential side effects, which can range from edema and fever to more serious complications like anaphylaxis and dysrhythmias. Oprelvecin is powerful but rarely used today due to its side effect profile. Still, it may be life-saving for patients with extremely low platelet counts. Always monitor closely for signs of fluid overload and allergic reactions. Let's shift gears and talk about anemia. Anemia is a condition where the red blood cells have a reduced capacity to deliver oxygen to the tissues. This can be caused by a loss of red blood cells, excessive destruction, or insufficient production due to deficiencies in essential nutrients. You'll see anemia everywhere in older adults, menstruating women, surgical patients, and cancer patients. Each case tells a different story, and treatment depends on the cause. Anemias can be classified based on the size and hemoglobin content of the red blood cells. We have microcytic, hypochromic, macrocytic, normochromic, and normocytic, normochromic anemias. Understanding these morphological categories helps us to pinpoint the underlying cause of the anemia. These terms may sound technical, but they help you determine whether a patient needs iron, B12, or folic acid. Don't treat all anemias the same. The symptoms of anemia can vary widely depending on the severity of the condition. Common symptoms include fatigue, pallor, and shortness of breath. In severe cases, patients may experience chest pain, heart palpitations, and even heart attack. Ask patients how their fatigue is affecting their life. Are they too tired to cook, work, or climb stairs? These clues help you assess severity better than labs alone. Vitamin B12 deficiency is a common cause of anemia. Often, this is due to a lack of intrinsic factor, which is necessary for B12 absorption. Pernicious anemia, a specific type of B12 deficiency, can affect both the hematologic and nervous systems, leading to serious neurological complications. Many patients don't even realize they have this until neurological damage sets in. Always ask about GI surgeries and look for signs like confusion or numbness in extremities. Folic acid deficiency is another important cause of anemia. This can be due to insufficient dietary intake, alcoholism, or malabsorption disorders. It's especially important to ensure adequate folate intake during pregnancy to prevent neural tube defects. In prenatal care, folate isn't optional, it's essential. Deficiency during pregnancy can result in neural tube defects like spina bifida. Iron deficiency is the most common cause of anemia worldwide. This can be due to GI bleeding, blood loss during menstruation, pregnancy, or surgery. Treatment involves increasing dietary iron intake and taking iron supplements like ferrous sulfate. Clinical tip: women, especially those with heavy periods or multiple pregnancies, are often iron deficient. Always assess menstrual history, GI bleeding, and diet. When administering ferrous sulfate, it's crucial to monitor hemoglobin and hematocrit levels. Use the Z-Track method for IM injections, and advise patients to take liquid preparations through a straw to prevent teeth staining. Be aware of the black box warning regarding accidental overdose in children. Make sure patients know dark stools are expected, not a sign of bleeding. And never give iron with dairy. It blocks absorption. But pairing it with orange juice, that's a win. Let's test your knowledge with a practice question. Which patients are at highest risk of having pernicious anemia? Take a moment to consider the options. The answer is D, female with history of gastric bypass. Great job if you picked D. Gastric bypass removes the part of the stomach that secretes intrinsic factor, which is essential for absorbing B12. These patients are at high risk for pernicious anemia and need lifelong supplementation. Here's another practice question, this time focusing on nursing interventions. Which interventions should be included when teaching a parent how to administer oral iron supplements to a 2-year-old child? The correct answer is B. Give the medicine with orange juice and through a straw. Yes, orange juice helps absorption, and a straw avoids tooth staining. Mixing with formula can interfere with taste and reduce intake. Tarry stools, totally normal.